I want to thank Dr. Cameron Kaiser for once again answering our questions on our biweekly call. Dr. Cameron Kaiser has done a wonderful job here in the community in helping keeping us safe. I'd just like to invite Dr. Kaiser to give us a brief overview before we go ahead and give the questions. Everybody is on mute. If we have additional questions, please put that into the chat box. And if we have time permitting, we'll answer those. Dr. Kaiser, to you.
Thank you, Dr. Holmblad. Good evening, everyone. Today we added 326 cases and 5 new confirmed deaths due to COVID-19 for a total cumulative case count of 48,956 and a total cumulative COVID-19 death count of 922, with at least 26,382 individuals considered recovered. On the clinical side of COVID, we are investigating several outbreaks, including at least 2 reports at acute care hospitals, which we are attempting to confirm. There is some reason to believe, although I stress that investigation is still ongoing, that these may be due to premature clearance of healthcare workers. And again, I stress we're still looking into this, but particularly for skilled nursing and long-term care facilities, improper clearance is going to be one potential way that disease spread can get back into those populations. We lifted the acute care public health approval requirement based on facility complaints, but we are still requiring public health clearance for high-risk settings where an outbreak has occurred and the facility is on restriction. If you are the one clearing individuals, the CDC non-test criteria should be your minimum guideline. While we do not recommend retesting except in those rare situations where someone is unreliable or maybe so significantly immunocompromised that they might shed viral particles longer. And again, I stress those situations are exceedingly rare. In Riverside County, we've adopted modified criteria. Where to be cleared, they must have 24 hours afebrile with significant improvement in symptoms, and that's the CDC standard as well. And at least 10 days must have elapsed since the last positive test. If they retest, since we cannot distinguish junk RNA from viable virus, I have established the policy that that 10-day clock starts over. So please advise your patients strongly not to do that. No public health authority, in fact, advises recommending a negative test as a condition of returning to work after having COVID-19. And we estimate that as much as 17% of our testing capacity is being consumed by useless multiple retests, so we can't screen out before they get there. So please help us to eliminate that source of inefficiency. California is one of the 5 jurisdictions selected by the CDC and the U.S. Department of Defense for pilot joint planning missions for COVID-19 vaccine distribution. Although the ACIP and the National Academy of Medicine are currently considering the problem of making sure that distribution is equitable and prioritized to the right people, there are certain planning assumptions in play, namely that there are going to be limited doses available. We expect that there will be a supply crunch. They will not be available any earlier than the fall, and I'm not even sure that will happen. And initial deployments will be to the critical care workforce in healthcare and essential industries, as well as those high-risk populations, particularly in long-term care facilities. The vaccine plan is also accounting for the possibility that multiple vaccine candidates may be in play. It is may not be and probably will not be one single vaccine which is being considered for these pilot missions, and multiple doses of a particular vaccine candidate may be required. California is, of course, a single jurisdiction in the federal sense, but obviously there are 61 independent freestanding health departments below the state level, and the state plan for the distribution has yet to be determined. Locally, however, we would probably do some sort of distribution strategy similar to what we did for H1N1 in 2009, which many of you will recall, using points of dispensing in the same fashion that we would do for any other form of mass prophylaxis. I'll have more to say about that in future meetings. In the meantime, of course, nobody wants the double whammy of the flu and COVID-19 at the same time. There is some hope that if people are doing the needful with social distancing and facial coverings, that the flu season may not be that bad. But I think that July taught us that people get sloppy very quickly, so I don't think we're going to be counting on it. This year's flu vaccine is somewhat different than last year's. The trivalent form, if anyone is still using that, is A Guangdong for the H1N1 component, A Hong Kong for the H3N2, and B Washington for the B Victoria component, all 3 of which are different from the 2019-2020 formula. The quadrivalent is that plus B Phuket for the B Yamagata component, which is the same. For those of you watching the Southern Hemisphere, as I do, because I have family over there, Australia has not yet assigned a vaccine effectiveness to their particular formulation. Although I do note the majority strain detected has been H1N1 flu A, which is a better prognostic factor for vaccine production. That said, they do have a different vaccine formulation there. They are using A Brisbane and A South Australia for the H1N1 and H3N2 components respectively. 65% of the H3N2 isolates were antigenic matches, but only 44% of the H1N1s were. So it may not be an apples-to-apples comparison to make to the North American formula. One last note before we get to the questions, please don't forget about West Nile. While case numbers have been low, positive mosquito detections have been found in multiple locations this summer. People are staying at home, or at least they should be, and this may make them greater risk for mosquito bites if they decide to have that backyard staycation. While COVID-19 testing should be first in your mind, given its spectrum of symptoms and our local prevalence, particularly for meningitis or encephalitis presentations with no clear alternative cause, you should strongly consider West Nile serology, and of course keep in mind that the disease is still considered endemic everywhere in Riverside County. With that, Dr. Holmblatt, I'll hand it back over to you for the questions.
Okay, thank you very much, Dr. Kaiser. Question number one, have transfusion reactions to convalescent plasma, specifically Trolley, been reported?
Yes, transfusion-related acute lung injury has been reported with COVID-19 convalescent plasma, and this wouldn't be a surprise because it would really be a risk for any plasma infusion. The risk does not seem to be especially higher for COVID-19 convalescent plasma in particular, but I also note you should remember convalescent plasma is still considered experimental, and the optimal dose timing and the particular types of immunoglobulin have yet to be determined. Similarly, other risks, such as transfusion-associated circulatory overload, my favorite acronym is TACO, and allergic reactions must be considered against the promising but relatively unclear evidence of efficacy. The FDA's official statement says, in short, and I quote, although promising, convalescent plasma has not yet been shown to be safe and effective as a treatment for COVID-19.
Okay, thank you. Question number two, Riverside County still remains with a high number of cases in the California County monitoring list, and numbers are constantly high for the last few consecutive weeks. Schools and classrooms will become the next incubators for large coronavirus outbreaks in our community. Test results were available for 344 summer camp attendees, the CDC reported. Among them, 76% of the kids tested positive. These findings, they quote, these findings demonstrate that SARS-CoV-2 spread efficiently in a youth-centric setting, resulting in a high attack rates among persons in all age groups, despite efforts by camp officials to implement most recommended strategies to prevent transmission. My question is, what are we doing as pediatricians and as our local public health to prevent schools opening too soon? I agree with school opening as soon as possible, but only if this situation is safe for our community. If the rate of community transmission is much lower than it is today, and if the schools agree to reducing class sizes, and of course, if facial masks are mandatory, then are we ready in
Oh, looks like we lost him. I'll go ahead and finish the question. Then are we ready in Riverside County for safe schools reopening? Can private schools open sooner and without approval than the public schools? I think what this question really hits on is that the single greatest predictor of school transmission is community transmission. We do have district level data, and we update this on a regular basis and send it to the superintendent of schools. And when we account for the relatively low level of pediatric testing, which is still a problem for surveillance, it turns out that kids get COVID-19 at about the same rate as everybody else. And during our July surge, pediatric cases went up in about the same proportion as they did in adults. They do seem to have much less clinical morbidity, at least in the short term. Indeed, MISC may simply be the pediatric presentation of severe COVID-19 disease rather than a unique syndrome associated with the virus. But we have certainly seen the phenomenon of long haulers in adult cases of COVID-19. And I would certainly hate to find out that similar phenomena occur for children later in their life. The argument really at this point then becomes how big a risk are they for spread? And teenagers and older kids seem to be at least as effective at spread as adults. And if community transmission is high, examples such as the camp outbreak you cited prove that there is indisputably as big a risk as other members in the population. This is why there is no middle school or high school in-person instruction allowed for counties presently on the statewide monitoring list, as Riverside County presently is and will probably be here for some period. The question mark then is for younger children. There was a South Korean study that appeared in MMWR, which most authorities believe was fairly high quality, and it seemed to indicate that spread was less likely from children under 10 years of age. You can argue about why that's occurring. The current theory is that this may have something to do with their lower prevalence of ACE2 receptors, but their viral loads are similar, so we have to assume that at least some spread is possible. Nevertheless, the position of CDPH is that these younger students are less likely to derive educational benefit from distance instruction, which is also true. So we need to balance those two factors. CDPH does allow county health officers to approve waivers with state concurrence for transitional kindergarten through grade 6 schools when the countywide case rate is under 200 cases per 100,000. We are dipping below that, assuming no more shenanigans with Cal Ready, which I'll talk about a little bit later because we have a question on that too. Schools would have to meet the state standard. They would have to have plans in place for response closing, surveillance testing of their staff every 2 months, and cohorting the students. And they would be required to adopt all of the CDPH infection control recommendations, including masking guidelines, requiring masks for all students grade 3 and up, and recommendations for all students 2 years and up, and of course the recommendations for class size, class layout, and social distancing. Now, this is necessarily a promise since none of them are open yet, but we would expect them to make a public statement to that fact, and all of our applications will be public for community review. We have not granted any waivers yet. We are likely to at least grant some low-risk ones. I might as well find out how it plays out. No one wants a school outbreak that was avoidable, but we can learn some things from low-risk openings before we make any other moves. And we would continue our surveillance testing and our data analysis on the pediatric testing that we do to see if numbers change in certain areas. Now, I should note that waiver applications that are approved are discretionary. Either myself or the state can veto a waiver or retract a previously issued one. And I want to make it clear that applying for a waiver is not a rubber stamp. We've had some schools go out and say, we're going to open on this and this date. And you know what? I'm saying, respect the process. I do have a say here. And I don't have to grant you a waiver for any reason at all. We're going to try and be fair about it. And as I say, I want to at least learn something where I can figure it out. But the process is purely discretionary. If a school gets a waiver and they offer grade 7 and up instruction, that would still remain closed. This covers transitional kindergarten through grade 6 only. Because the state requires that teachers' unions be involved, this is causing a bit of an equity issue for those lower income students who may not be able to access their elementary school due to union concerns, even though I stress that public and private schools alike would be eligible for waivers as well. Therefore, we expect that the private schools will be able to apply most expeditiously since most of them are not union shops. It is a nice little side benefit that many of the private schools will be smaller in number and gives me a little bit easier way of monitoring them, but I may still consider caps or phase-ins if we get flooded with applications, since the process is to study these schools, not merely to rip off the scab and see how bad the bleeding is. Interest has not been excessively high, which surprised me, but that doesn't mean that schools that didn't ask won't send in an application, and I'll have more to say about that in later meetings. One last note before we leave this question. Some of you will have noted that San Bernardino County has opened up some districts on the basis of regional numbers, despite the fact that they are actually over the 200 per 100,000 population threshold. To be fair, they are trending down too, but they have not broken that number. Our position is that they are outside state guidance in doing so. There are no political subdivisions in California below the county level except for cities, and no city in Riverside County, or for that matter, San Bernardino County, has a separate public health department. And frankly, this is what you want, because in the absence of guidance as to what constitutes a region, I'm sure there would be a lot of people who would agree with me simply defining a region as everywhere there isn't a COVID-19 case, and then everybody can open up. Since that's clearly ridiculous, and we do not want regions gerrymandered, until CDPH says differently, we are going with county-wide numbers, full stop.
Okay, thank you. Question number 3, what is the county's public health department's position on schools that are opening against the guidelines that have been established for reopening?
Our position is very straightforward. We believe they're doing so against the state order, and they will be reported to the state accordingly. Additional action may be taken. County Council has been taking note of schools claiming they will reopen. So far, we are not aware of any that has. If you know, please let me know. For those that have made a public statement claiming that there will be, we are watching to see if they do. Again, part of the reason of posting our waivers that have been approved to our website is to make sure that the county is aware, or sorry, the community is aware of which schools actually do have a waiver for operation, so we can cut down on some of those inquiries, but right now, nobody has one.
Okay, thank you. Question number 4, traveling as a physician overseas, are there any exceptions for waiving airport quarantine?
Unfortunately, if you are flying overseas, you are at the mercy of the quarantine requirements of the country you are entering. I am not aware that any country that requires quarantine will waive it for an American healthcare worker. It's possible. I don't know all the requirements for various countries, but I am not aware of one that has a special exemption for that particular category. On your return to the United States, you are advised to complete a 14-day quarantine at home, regardless of the country which you travel to, with the possible exception of New Zealand, but this is now considered, or I guess North Korea. North Korea claims they have no cases either, so I suppose you could do that there too. This, however, is a voluntary requirement. Nobody's going to call and check on you, but we strongly recommend that you do so.
Okay, thank you. Question number 5, if a patient has IgG antibodies to COVID-19 virus, do I report that to Public Health Department, or is that automatically done by Quest?
The answer to that question is yes. You should report that to us at minimum on the standard confidential morbidity report form, and Quest has its own requirement and will doubtlessly send us a report as well. However, Quest doing so is under a different portion of the California Code of Regulations, and that does not absolve you of your own clinical requirement. Now, with an antibody test in particular, clinical judgment should indicate if you believe additional testing is required, of course, because antibody testing cannot be used presently to determine if anyone is immune or infectious. If you have reason to believe that that infection is recent, then I would strongly recommend a PCR test in addition at that point.
Okay, thank you. Question number 6. Hospitals have their respective employee health departments clearing their exposed clinical associates to return back to work. How do you recommend independent physicians, 1, report that they have been exposed, and 2, obtain clearance to return back to work since they are not hospital employees?
Yeah, I wrestled with this one for a while. The problem is there really isn't a good general answer to this question because it's probably going to depend greatly on where you have privileges. My recommendation would be to inquire at the medical staff office for the desired procedure. For getting clearance to return to work, even as a contractor, they are still going to have some means to indicate you are appropriate to return. For example, we've had surgeons who have tested positive and they had to get cleared through the facility which they had privileges at, and you may have to do it with multiple facilities to let them know that you were positive. And that would be the case whether you're in an inpatient or outpatient setting. They should not require you to obtain a negative test before you return. As I mentioned, no public health authority recommends that, but they may ask you to obtain a second physician's evaluation. Naturally, you should be prepared to present any testing done and the relevant dates of exposure testing and or symptoms. Obviously, if you're the operator of your own office, then your clearance is going to be on your honor. But for facilities where you are an independent contractor working for them, that's something you're going to have to run through their medical staff office to make sure you're in alignment with their procedures.
Okay, thank you. Question number 7. We may have covered this in some of your other questions in the past biweekly conferences. If a patient tests positive for COVID-19, how often should they be tested again, and how long before they are considered to be no longer spreading the virus?
The rule of thumb is if a patient tests positive on either an antigen or a PCR test, they should not be tested again. As I mentioned in my introductory remarks, unless they are one of the rare circumstances where this individual is unreliable, or you believe they have such profound immunocompromise that they really might be shedding viral particles longer, and there has been some anecdotal reports of that. There is otherwise no clinical role for retesting a positive patient in the short term. That also goes for antigen testing as well. There have been some questions about the specificity of particular antigen testing, and you may wish to check the particular assay which you select for your practice if you choose to offer this testing. We'll talk a little bit more about that at the end. But virtually everybody agrees that once you get a positive, you should treat it as a positive regardless of the modality. Some authorities recommend that they may not be tested again for at least 3 months, in fact, as they may shed junk RNA for at least that long. And there's also some question about how long their immunity would last, even though I don't think anybody is prepared to say that people are immune at least for 3 months after they test positive. Nobody's recommending they get tested in that time frame either. Again, unless they are unreliable or highly immunocompromised, we consider individuals to be non-infectious 10 days after the last positive test in Riverside County, assuming no fever and substantial symptom resolution the past 24 hours. And if they were never symptomatic, then 10 days is fine. Before we go on, why don't we do the 8 and 9 together, since I think these questions are really related.
Has the state lab caught up on the reporting backlog? How did that affect Riverside County? And question 9, what the consensus, does Riverside County appear to be on the downward trend? Hospitalizations appear to be going down, but our positive rate continues to increase.
We believe that the state backlog has been cleared mostly, although there is still a big divot in our cases for a period of about a week retrospectively that we're trying to resolve. I mentioned to the state this issue on a call this morning, and they're also looking into it. Our numbers actually have been, during that period, were quite low, as was San Bernardino counties and LA counties. And we do get some level of tests through other means, particularly through Epic. We get some level of those results through through clinician reports. Everybody who gets tested through a county site necessarily gets registered in Epic for tracking purposes, and those results actually go back through Epic. There was a terrible period of time where I was a physician of record for every single coronavirus test, and that meant hours of me in Epic trying to clear that log. But anyway, nevertheless, we did have reason to believe that those weren't being followed up on, and we could determine it was artificially low through other results. There still seems to be some delay with some results, and not all of that is based on laboratory issues, but we're at the point where we do believe that at least the vast majority of the historical results are in the database. Now, actually, our hospitalization, overall case rate, and positivity rate are actually all trending down, and we believe this to be caught up. Our positivity rate in particular was as high as 16% during the July surge, but is now a bit over 10%. Make no mistake, this is still higher than the state's 8% cutoff, but it is still an improvement. Unfortunately, a fair bit of the decompaction in the hospitals can also be attributed to lagging deaths, which during the July surge started rising about 4 to 5 weeks later. You'll recall the last week and a half or so, we had some particularly high numbers for a few days. San Bernardino County observed a similar phenomenon. I think this lag can be attributed to the better care that people are getting in the ICU. I think some of the efforts that our critical care physicians are making are nothing short of heroic. But some, unfortunately, will still succumb. I know this personally because a friend of the family lost her mother that way. She had a prolonged period on the vent. They could not successfully wean her before she became hemodynamically unstable, despite the fact that they threw pretty much everything at her, from convalescent plasma to remdesivir to tocilizumab, and she still didn't make it. And we are most concerned, of course, about Labor Day because the holiday weekends before was really where we took it on the chin. And I think that our positivity rate, even if we do drop below that 8% threshold, there is still more than enough virus circulating to enable another surge again if we're not careful. And we are continuing to stress to the public they should not become complacent about this, or we're going to be looking at another situation like we had in July.
Question number 10, are you recommending that physicians beginning testing more in their practice rather than refer to the drive-through sites? If so, are the guidelines on testing, retesting we should follow?
As far as I'm concerned, you should do as much testing as you feel comfortable doing. For some groups, such as healthcare workers in skilled nursing facilities, educational staff in schools, they actually have a requirement to be retested on a regular interval. And frankly, I just don't have enough capacity as a county to be able to do that for every single SNF or long-term care facility or school. And there may be some opportunities for physicians to partner here as an income stream, since I know that some practices have been impacted by telemedicine-only options, and this may be a potential revenue source for those facilities that need it. The only advice I give is, of course, not to do antibody testing for diagnostic purposes. And if you use rapid antigen or PCR testing, that negative results may need to be considered presumptively negative due to their overall lower sensitivity. PCR in that case may be needed to confirm. I would still consider to be PCR the gold standard for diagnostic testing. And as I mentioned before, at least one antigen test has had an issue with specificity as well. So do check the EUA's performance characteristics. The FDA lists the specificity and sensitivity for all the tests that they have with a CLIA waiver before selecting a rapid test for your practice. As I mentioned, PCR is still considered the standard for diagnostic testing. But antigen testing is still an option for the right patient, especially if the pretest probability is sufficiently high. They were exposed, they went to a country where they might have been exposed, they have symptoms, or for someone who needs surveillance, regardless of their symptomatology or exposure history, because they're going to be on one of those rotating surveillance plans, and we're going to hopefully get another bite at the apple. Because of PCR reagent impacts at the national level, whatever expansion of testing occurs in physician practices, it's probably almost certainly going to be antigen-based, especially because there are now CLIA-waived assays available, and you don't need to have a CLIA lab on your practice to be able to do it. But I still continue to recommend that asymptomatic people at least be considered for testing. And the state still lists them as a tier 4. They may be lower priority, but they are still on the list. And I've said this many times before, if we are not testing asymptomatic individuals, then we are not doing surveillance. Otherwise, we're going to have a situation like New Zealand did, where suddenly, whoops, they have a case, and there wasn't enough testing out in the community where they were able to detect at the time. Fortunately, they were reacting fairly quickly to that. But in our situation, we may have multiple small fires break out, and we really need that early warning indicator to jump on it quickly. The other reason is the standards. Our positivity rates are going to get distorted without asymptomatic testing because people will conclude, and unfortunately with justification, that our positivity rates are being biased towards those people who are already likely to be ill. And they're going to say, well, our positivity rate should be higher. And I make exactly the opposite argument. Our positivity rate should be lower if we're going to actually have the standard out there where we're getting control of it. If we want positivity rates to reflect a true population sample, then our testing also needs to be a true population sample. And that is only going to happen if we have physician practices involved as well.
Okay, thank you, Dr. Kaiser. We have questions below related to testing that have been addressed prior. Is there any further clarification needed at all for question number 11?
No, our protocol for healthcare workers is pretty much the same. As I mentioned, remember that we have the standard in Riverside County. We go by the last positive test to discourage people from retesting. They should not be tested again as a condition of employment unless you believe that they're in one of those rare categories where they are unreliable. And if they're unreliable, I question why they continue to be employed in your practice. Or they are one of those profoundly immunocompromised individuals who may actually have that anecdotal risk of shedding a live virus. You should not be testing them again after they have tested positive, and they can be cleared after the 10-day, 24-hour.
Okay, thank you. We do have something in the chat room. Do you have time to answer one more question?
Sure.
Okay, I'll fire this up here. Um, this is from Dr. Roger Rantham. Can you comment on the potential availability of the saliva test?
Hi, Dr. Raj. I'll comment on the potential availability. It's lousy. We have not been really able to get good supplies of any saliva tests so far. We're still having trouble even with the Abbott rapid PCR as well. The antigen tests actually are the one test which are available in some numbers. COVID Clinic, which was one of the pop-ups which started doing testing, Elevated Health is their DBA. They were able to get them in some quantity, and they actually are using an EUA, an assay with EUA, so they are finally on the up and up. But we haven't had a lot of luck on the saliva tests yet. There is a profound amount of interest. We expect that they will produce those in greater numbers because I'm sure they will sell. But I'll say generally, I've been quite surprised at how poor our supply chain has been for diagnostic testing in general. It really is startling how bad our availability of reagents are for the PCR test, which is really the gold standard. And we're seeing some similar impacts on other testing modalities as well. I think that there's some promising saliva test. I think that it will become a much bigger part of our practices, but right now I think supply issues are limiting it as much as they're limiting others. Hopefully that will change in the near future.
Well, thank you, Dr. Kaiser, for joining us again. We look forward in 2 weeks to go through another question and answer period. Once again, on behalf of the Riverside County Medical Association, I want to thank you for sharing your views with us and sharing your expertise. We do really appreciate it. I know that I personally appreciate it and my family appreciates it. Thanks again.
Thanks as always, Dr. Holmgren.